this week we'll have Dr. Ryan DeSanti, who will present on point of care ocular ultrasound. Ryan is a published author and expert in ocular ultrasound and is at St. Christopher's in Philadelphia and has been leading the efforts there to teach. And it's our privilege to be able to have him speak today on an emerging phenomenon that we're looking at in terms of its use in the critical care setting.
Thank you, Eric, for letting me talk about ocular ultrasound today. And so ocular ultrasound is commonly utilized for the evaluation of things such as acute vision loss, eye trauma, and for suspected intracranial hypertension and estimation of intracranial pressures. And so for processes that are associated with acute vision loss, ultrasound can be helpful for evaluating for retinal detachment and vitreous detachment, vitreal hemorrhage, and central retinal artery occlusions. For eye trauma, ultrasound can be helpful for evaluating for foreign body, lens dislocation, globe rupture, retrobulbar hematomas, as well as retinal detachment and vitreous hemorrhage. And then for assessment of intracranial pressures, we can look at things like optic nerve sheath diameter and assess for optic nerve edema, as well as assess pupillary light response. Of note, globe rupture is considered a relative contraindication for ocular ultrasound, as it can increase intraocular pressures, worsening the globe rupture. And so if this is suspected, it's best not to do ocular ultrasound. Of course, we all know that dilated ophthalmologic exam is considered the gold standard for assessment of the posterior chamber of the eye. Although access to trained ophthalmologists can frequently be limited, either because of availability at a particular institution or because of the time of day and the ophthalmologist's availability. Also, ultrasound can be helpful as many in the acute care setting have limited training and or confidence in ophthalmologic examination. And so point of care ocular ultrasound can be helpful, is relatively easy to learn. And of course, we know that many patients in the intensive care unit can be limited in their ability to open their eyes. Of course, we've all seen patients with unilateral eye edema, either from trauma or neurosurgery, things like that. And we've also seen patients who have bilateral eye edema from things like fluid overload, capillary leak syndromes. And so ultrasound can be helpful in both of these cases. As a review of the relevant ocular anatomy, the first thing or most anterior structure in the eye is, of course, the cornea, followed by anterior chamber. Then we have the iris, as well as the pupil. Then comes the lens. Next up is a fluid-filled structure called the vitreous chamber. Posteriorly on the eye, we have the retina, which attaches to the optic nerve that comes out posteriorly in the back of the eye. And in the middle of the optic nerve, we have the central retinal artery and vein. And so when we look at ocular ultrasound, this is how the eye will be oriented on the ultrasound screen. And so again, we have the cornea anteriorly, followed by the anterior chamber. We have the iris and the pupil, the lens, the vitreous body, the retina posteriorly, the optic nerve, and then the central retinal arteries and veins. And so this is how it looks on ultrasound. Again, the cornea, then we have the anterior chamber, we have the iris and pupil, the lens, the black fluid-filled structure, hypoechoic structure, is the vitreous body. The retina attaches posteriorly to the optic nerve, and then the central retinal artery and vein in the center of the optic nerve. And so to perform ocular ultrasound, we will use the high frequency linear probe. A smaller footprint probe, such as a hockey stick probe, can be useful to enhance contact with the eye. We do the exam with the eye closed, with or without Tegaderm. Many sources, many reviews will recommend use of Tegaderm, but there is a study I'll talk about here in a second that has demonstrated potentially slightly worse image quality. And so people may elect not to use it. And then ample ultrasound gel and enough ultrasound depth in order to be able to assess the optic nerve. And so this is what it looks like on an eye using the hockey stick probe, gel, and then without the Tegaderm. And so, as I said, in 2022, there was a randomized control trial which looked at use of Tegaderm versus no Tegaderm to complete ocular ultrasound. The study looked at a total of 90 patients. It was an adult study, so the mean age was 46 years, and 64% were female. The most common chief complaint for which the providers were performing ocular ultrasound was headache at 91%, blurred vision, double vision, and black spots in the vision were also some of the relevant chief complaints. And then they randomized patients to receive Tegaderm on either the left eye or the right eye, with the contralateral eye serving as the control for the patient. And so they assessed both the quality of the ultrasound and then ability to make a diagnosis. And so they assessed the quality on a scale from 1 to 5, and they found that the image quality with Tegaderm was slightly worse than with no Tegaderm. And so on the scale of 1 to 5, the mean quality score for Tegaderm eye was 3.39 as compared to 4.43. And the percentage of acceptable images, which they defined as a quality score of between 3 and 5, was also higher in the group or the eyes with no Tegaderm. And so 82.5% or 83% of eyes examined with the Tegaderm were considered acceptable, a score of 3 to 5, compared with 98% of eyes without Tegaderm. And then they asked patients to rate their comfort level or discomfort level on scale from 1 to 10. And the mean discomfort score was 1.4 with Tegaderm compared to a score of 1.73 with no Tegaderm. And so there was no difference in patient comfort between Tegaderm and no Tegaderm, and slightly improved image quality with no Tegaderm use. And so just as a review for performance of ocular ultrasound, we will use the high frequency linear probe. If possible, a smaller footprint may be helpful to enhance contact. Patient eye will be closed, may use Tegaderm, may not use Tegaderm, depending on preference. Ample ultrasound gel, and then enough depth to assess the optic nerve. Ideally, we'll be performing both in the transverse view, so left to right, and then sagittal view, superior, inferior, and then scanning in the transverse view from superior to inferior, and in the sagittal view from the left side of the eye to the right side of the eye, and comparing both eyes to each other. And so again, here's a review of the relevant structures. We have the cornea anteriorly, anterior chamber, We have the iris, the lens, the vitreous, the retina, then the optic nerve, through which the central retinal artery and vein run. And so most commonly, or one of the uses for ultrasound, which is increasingly being evaluated in the intensive care unit, is to evaluate for intracranial hypertension. This is done by measurement of the optic nerve sheath diameter. And so you obtain the ultrasound view, and the optic nerve is the hypoechoic structure at the posterior portion of the eye. The way we measure the diameter is measured 3 millimeters distal to the posterior portion of the eye. So measure down 3 centimeters and then measure the width of the hypoechoic region. And so here's a second example. Measure down 3 millimeters posterior to the eye, and then measure the hypoechoic region. There have been multiple studies in the intensive care unit trying to compare optic nerve sheath diameter with intracranial pressures. I was just going to go through a few of the studies. One which compared 72 children who were treated at a university hospital in Germany on a neurosurgical service between January 2016 and 2018. They performed optic nerve sheath diameter immediately prior to invasive intracranial pressure measurements. They looked at a variety of different disease processes, including hydrocephalus, traumatic brain injury, craniosynostosis, pseudotumor cerebri, tumors, and then various other disease processes. When they evaluated the optic nerve sheath diameter in children who are older than 1 year of age via linear regression, they found relatively good correlation between the nerve sheath diameter and intracranial pressure. But this was much better correlation than what they found in children who were less than 1 year of age, in which the correlation or R was 0.63 for children older than 1 year, compared to 0.21 for children less than 1 year. And the authors had hypothesized that it was because these children had open fontanelle, may make the exam less reliable. In a separate study, which was completed in the intensive care unit of 16 children who were suspected to have intracranial hypertension or at risk of intracranial hypertension with invasive intracranial pressure monitor, the researchers performed optic nerve sheath diameter assessments, 136 of them, and compared these with invasively measured intracranial pressures, and found that the nerve sheath diameter was not associated with intracranial pressures. They did ROC curve assessment of the optic nerve sheath diameters and compared with the ability to determine an intracranial pressure higher than 20 and found an area under the curve of 0.52. When they looked at the intracranial pressure as a continuous variable, the area under the curve was a bit better at 0.67. And so looking at review articles, there are many limitations to the current literature evaluating optic nerve sheath diameter, namely that there's significant heterogeneity between study designs. And so the diagnostic accuracy of optic nerve sheath diameter cutoff values in predicting elevated intracranial hypertension compared with invasive measurements at different thresholds and for different age patients and across different disease processes needs further investigation. Though it is probably a useful extension of the physical examination in children as an initial non-invasive assessment of patients who are at risk of or suspect of having increased intracranial pressure. And repeated optic nerve sheath diameter ultrasound assessments may be of value in assessing response to ICP-directed treatments and follow-up of patients when invasive ICP monitoring is not available. Common, or one of the more commonly cited studies for normal optic nerve sheath diameters in children comes from the study in 1999 when they evaluated 102 children who were age 0 to 15 to evaluate their optic nerve sheaths. None of these children had neurologic or ophthalmologic disease. And what the authors found was that children less than 1 tend to have a range of optic nerve sheath diameters between 2 and 4, and then children over 1 between 2 and 3 millimeters. And the cutoff values they determined for abnormal enlargement of the optic nerve sheath diameter was 4 millimeters for children who were less than 1 year and 4.5 millimeters for children who are older than 1 year. So this is a commonly referenced article for normal values in children. But as I said, all of the papers do show enormous variability in proposed reference values. And so standardization across different patient ages and disease processes is difficult. And so further studies in children with suspected intracranial hypertension are needed to try to standardize diagnostic ultrasound procedures and identify accurate and fixed reference values. And so these are the commonly proposed normal cutoff values: infant optic nerve sheath diameter less than 4 millimeters, children less than 4.5, and adults less than 5. And again, the way that we measure optic nerve sheath diameter is 3 millimeters posterior to the eye, and then measuring the hypoechoic region across. Another way that we can use point of care ocular ultrasound in the intensive care unit is to measure the pupillary light response to contralateral light stimulation. This is probably most valuable in patients with unilateral eye edema who you're not able to open the eyelid for a particular reason, but are able to open or shine light in the other eye. And so if you get the ultrasound perpendicular to the pupil, as is shown in this caricature, you will get a ultrasound image which has circle, which represents the pupil. If you put MO on it, will produce obviously the M mode tracing. And then if you shine light in the contralateral eye, you will be able to measure the pupillary constrictive response to contralateral light stimulation. Some of the other common things that ultrasound can be used for, as I said before, acute vision loss or traumatic eye injuries. Wanted to go through some examples of these. Retinal detachment can be common in both trauma and acute vision loss. More acute vision loss in adult patients, but certainly trauma in pediatrics. We'll have the hyperechoic retina will detach from the posterior portion of the eye. Typically will still be attached at the optic nerve. And so as you scan through, you'll see the hyperechoic structure, which is attached to the optic nerve posteriorly. Posterior vitreous detachment does appear similar to retinal detachment, though the hyperechoic portion does not attach to the optic nerve in this case. Posterior vitreous detachment can be seen also in trauma, so as part of the same differential diagnoses. Again, the hyperechoic line in retinal detachment will be attached or should be attached to the optic nerve, whereas posterior vitreous detachment will not be. So here's an example of posterior vitreous detachment. Foreign bodies can also be seen on ocular ultrasound. Will typically show up as a hyperechoic structure within the eye, such as this example here, or this example here. And then lens dislocation is also something that we can pick up, may be seen in cases of acute trauma. And so this is when the lens dislocates from the iris. And so normally should see the lens between the iris anteriorly. In this example, you can see the lens has detached and is now posterior within the eye. Also can see retrobulbar hemorrhage in cases of trauma. And so this is hematoma, which accumulates in the posterior chamber of the eye around the optic nerve. Because of pressure on the posterior portion of the eye can cause disfiguration of the posterior portion of the eye, appearing as a triangle or what they call a guitar pick, such as in this caricature here on the side. And here's ultrasound example of this. And so you have triangular shaped portion of the posterior part of the globe representing retrobulbar hemorrhage. Vitreous hemorrhage is something also which we can pick up, which is hyperechoic debris within the eye itself. So here is an example of vitreous hemorrhage. And then finally, central retinal artery occlusion, something which can be picked up using ocular ultrasound. This does require use of color Doppler. And so putting the Doppler on the optic nerve, we should see flow of both the artery and the vein. And so in this example, flow towards the ultrasound probe at the anterior portion of the eye is red. Arterial flow towards the probe, and then blue is flow away from the probe. And so artery going towards the probe and then the vein coming away, as we can see both in this example here, as opposed to this example, which just shows the blue flow of venous blood without the orange color of or red color of the arterial blood. Again, representing central retinal artery occlusion. And so these are some of the common things which we can assess using point of care ocular ultrasound, optic nerve sheath diameter to look for increasing intracranial pressures, as well as pupillary light response, and some common eye pathology which can be associated with acute vision loss or with ocular trauma. And if anyone has any questions, of course, we'll be happy to answer them.